Right, good evening ladies and gentlemen. Welcome to Plymouth University, welcome to the Roland Levinsky building, and welcome to this evening's talk, which is on the topic of euthanasia. Now it's said that there are few things that are certain in life, but two are taxes and death. And actually, only one of those is certain, because you don't pay taxes if you don't get a job. The only thing which we can be certain of is that we're going to die. And this is a rather distressing thought for all of us, but it is actually true. It's going to come to us, it's going to come to our loved ones. And the topic of euthanasia is a particularly difficult talk to deal with. We don't shy away from difficult talks. Please come in, find yourself seats. There's plenty of seats down the front. We don't shy away from difficult talks, and this is really going to be a very challenging idea for us this evening. We've got two experts here. We've got Dr. Karalyn Patterson, who's a neuroscientist from Addenbrooke's Hospital in Cambridge. And we've got Dr. Geoffrey Stephenson, who's a consultant in palliative medicine, medical director at St. Luke's Hospice. I'm going to start by asking Karalyn if she would run us through some of the principles and philosophies behind euthanasia. What are the ideas that should govern our practice in this very difficult subject? Karalyn.
Well, I'm very pleased to be here this evening to talk about this complex but important issue that has been entitled Deciding to Die, Euthanasia, Consent and Dementia. And this is who I am, and these are the places that I work in Cambridge. And I've mentioned my qualifications here. I have a PhD, I'm a Fellow of the Academy of Medical Sciences, and a Fellow of the British Academy, not to try to impress you, but to note one qualification that I don't have. I am a neuropsychologist, neuroscientist. I'm not a medical doctor, so if and when you have questions of a medical nature, it will be more appropriate to address them to Dr. Stephenson. As Michael mentioned, I'm really going to talk more about the principles than the practicalities of this complicated situation. And there are a couple of reasons for this. First of all, euthanasia and assisted suicide, as you probably know, are illegal in the UK. Interestingly, suicide is not illegal. It was decriminalised in the 1965 Parliament Suicide Act. So suicide is actually a unique, completely unique situation on the UK law books. It's not illegal to commit the act, but it's illegal to assist somebody to commit it. Very unusual. A second reason why I'm going to focus on the principles rather than the practicalities is that from our point of view as UK citizens, there are places in Europe where it is legal, for example the Netherlands, but only for citizens of that country. So for us, it's not an option. But the world is changing very rapidly. Views on euthanasia in general and in dementia in particular are changing, and it may not be too long before the laws change here in Britain, and therefore I think it's worth discussing some of these issues. And I really just want to make 3 points. My first point concerns the question of fate worse than death. I don't know whether you know where this phrase originates. I didn't until recently. I looked it up on Google, a source of all information. And it turns out that its origin is, it was a euphemism for rape. And the idea was that a woman raped, a woman dishonored, would be better off dead. Now, I think very few people would hold that view nowadays. But some people might want to ask, and I'm one of them, Are there situations, are there fates worse than death? Now, I think that having or even caring for someone with severe dementia is really not within our power to imagine. Unless you've been in that situation, you probably can't really think what it's like. But you can have experience of these things without being in the situation. And 2 days per week at Addenbrookes Hospital in Cambridge, I see patients with dementia and their carers in clinic. And so I have quite a lot of experience of what their lives are like. And on the basis of this experience, I'd like to suggest to you that we should not simply assume that death is always a worse fate than life. And in particular, not necessarily worse than living, where the only guarantee is further deterioration. In this connection, I want to mention a recently published book which is very interesting, called 5 Days at Memorial, by Sherry Fink, who is a medical doctor and a specialist in medical ethics. And this book addresses harrowing questions in ethics during Hurricane Katrina in New Orleans. So 5 Days at Memorial means Memorial Hospital in New Orleans. When the hurricane struck, Memorial Hospital was very badly damaged. They had no power, and it was August 2005 when this happened, and it's very hot in New Orleans in August, and so they had no air conditioning, and because the building relies entirely on air conditioning, the windows are all sealed, and therefore they had no access to fresh air. They had no running water, and so within a very short amount of time, they had no water to drink, no water to wash, the toilets were overflowing. They had no fresh food, no light. It was a truly terrible situation. And there were about between 200 and 250 very ill patients in this hospital. And the medical staff were faced with questions of how to deal with these people. And they knew that if rescue were to come, it would come slowly because of damage to the entire infrastructure of the city. And that some of these patients either would not be able to survive until rescue came, or indeed might not survive the attempted rescue. Approximately 45 of the patients were given lethal injections of morphine, and they died. And the medical staff have been prosecuted for murder. Now, I think one can see that, in a sense, they did commit murder, but I think there's another perspective, and it's one that I would take, which is they thought that it would be better for these patients to die painlessly than to endure what would be likely to happen to them over the next few days. And I think that this, although it's not exactly the dementia situation, is an applicable kind of information. My second point is, what kind of death? When I say that dying may not always be the worst fate, I mean dying with dignity. No fear, no pain, no suffering of any kind. I mean the kind of death that we give horses, dogs, and cats if they are injured or terminally ill. It's always been a bit of a mystery to me why human and non-human animals are treated so differently in this regard. And I do know something about dying with dignity because I have a connection to Dignitas in Switzerland, and I therefore know that there are circumstances in which a human animal can be given the kind of pain-free, fear-free death that we do try to give to animals. My third point is the most difficult issue of all, and that's that of informed consent or choice, where somebody does not have the mental capacity to make their own decisions. There's no question that there are huge dangers in allowing someone else to decide when a person should die. But what I want to ask you to remember in thinking about this is that a person with dementia has almost no control over his or her life whilst still alive. For example, take the simple decision of whether this patient should be allowed to continue to live at home or be moved into a nursing home. That decision is almost always taken by someone else, not the patient. The point I want to make is that even while alive, patients with severe dementia are vulnerable to all sorts of mistreatment, whether it's to do with their financial affairs, where they live, who cares for them, how they're cared for, whether there's somebody always available to come if they're in need of something. So really, my third point is this. The idea that euthanasia would take away a person's right to self-determination, whereas keeping that person alive maintains it, is really a false dichotomy. Thank you.
Thank you, Karalyn. I think that's a very clear account of 3 points which we need to take into account, 3 principles which we need to think about. I'm now going to ask Geoffrey if you would look at the practical issues, the practical problems, what actually happens in practice.
Good evening. Can you hear me okay?
Yes.
Thank you, Karalyn. That was very instructive. And I come to this with my own experience of looking after the dying, and I think at the outset it's probably important to say that this whole area is one that's often very hotly debated, and it's important to remember that on whichever side of the argument you're on, there are people of deep compassion on both sides of the argument, and the arguments on both sides are very valid, and I just want to make that point at the beginning because I'm sure that even within an audience like this there will be a polarization of views. I thought it'd be useful before focusing in on the application to dementia itself just to summarize what it is we're talking about when we talk about assisted dying. And usually we're talking about one of 2 things: euthanasia, which is the intentional killing of a person by act or omission, or assisted suicide, whereby someone is helped to take their own life, and usually we mean by that a doctor will prescribe a lethal cocktail of drugs for them to take. Both of these, implicit in both of these actions, is the fact that it should be a voluntary act. And both of these, as we know, are illegal in this country at the moment. In terms of it, just summarising the arguments for why would we want euthanasia or assisted suicide, and they're usually argued probably on 2 broad themes. The first is one of compassion, that we need it for those who are facing a potentially difficult, traumatic death, or for those whose continued living is one of unbearable suffering. And the other sort of line of argument is along the lines of autonomy, i.e. our right to choose for ourselves, our right to self-determination. So as an individual I should have a right to decide when my life loses meaning, or when I face the prospect of what for me is a life that's not worth living, I should have the option of opting out and being helped to do that. There have been a number of attempts to change the law, and they've failed up to now, and it's probably helpful to know why they've failed. They failed largely on the basis of public safety concerns. So while acknowledging that there are some people who would take this option if it was available, regardless of what care can be provided alternatively, nevertheless, to change the law to allow it for that few poses far too great a risk for far more vulnerable people. So the concern that a right to die might become a duty to die, and that vulnerable elderly people might feel pressure, whether real or imagined pressure, but pressure nevertheless to request early death if that option were available. And in terms of bringing my own experience to this discussion, people facing terminal illness are already physically and psychologically very vulnerable, and they often struggle with many of the decisions they have to make. And I think maybe adding in the option of taking an early exit would, for some, perhaps many, actually increase their distress. That's my own personal view from working with the dying. I think the other concern is that people have is that this will simply be a first step on the road to greater liberalisation. That with time we would see an expansion from an initially limited, well-defined group of people who are opting for it to a much broader application. And in many ways, logically, that should be the case on the basis of compassion. Compassion demands it, really. If you're allowing it for a small group of people who have a short time to live, who are suffering unbearably, what about those who have longer to live, who are suffering unbearably? They have longer to suffer, so why are we restricting it to the last few months of life? And what about those who are unable to ask for it, but actually we think are suffering unbearably? Why should they be denied it when simply because they lack capacity? And I guess people with advanced dementia might fall into that category. Autonomy would encourage it, because if it comes down to an issue of simply choice of my own life, then why should illness, terminal illness, or even unbearable suffering come into it? If it's simply a matter of choice, why shouldn't we be able to exercise that choice? So it's quite likely that over time, as we've seen in Holland, there would be an increasing acceptance of these practices, cultural change in society, or shifting the moral compass, if you like, so increasing acceptance. Those coming on to those with dementia and the vulnerable, people will argue that if we can put in place appropriate safeguards, then we might be able to stop these unintended consequences of risks to the vulnerable and increasing liberalisation. And I think the problem with that is that it's very difficult for us to devise safeguards which are foolproof. Certainly those jurisdictions which allow this, they do not have foolproof safeguards, and it's quite difficult to see how one could safeguard against a sense of duty to die. I think in terms of application to dementia, those people with advanced dementia are probably some of the most vulnerable in our society already, and in many cases often subject to abuse. Is killing someone perhaps the ultimate abuse? We face in this country a demographic time bomb with an increasing aging population. It's estimated that in the next 20 years or so, over half of patients dying in this country will be aged over 85. And along with that goes the increased burden of dementia, other long-term chronic conditions, and the strain that's going to be put on our care services to look after so many people. Financial pressures, and we've experienced financial pressures already, will only add to the vulnerability of the elderly and put them at even more risk. So the risk of elder abuse is real, and in North America and Canada, where there have been numerous attempts, there's been over 100 attempts over the last 15 to 20 years to get the law changed in various states to allow some form of assisted dying, all of them unsuccessful except for one state. Increasingly, those moves are being opposed, and successfully opposed, on the basis of elder abuse. Elder abuse is rampant, it is felt, and this is simply opening the door to an open season on elderly people. And that's the battleground that's being fought in the States at the moment. In terms of applying, if the law were to change, and we were to apply the change of the law to those with dementia, it's fraught with problems, and Karalyn has touched on some of those already. What I've been talking about requires voluntary consent, requires mental capacity, and capacity is very strictly defined medically. and often quite difficult to assess and subject to individual judgment. We know that patients with dementia have a progressive loss of capacity, but that isn't always linear, and capacity can fluctuate. And I guess the big question in applying any new law to patients with dementia is, how much capacity do you need to make such a monumental decision? And when is capacity lost? Because at that point, someone else has to take over decision making. At the moment, people can guide decision making once they lose capacity by stating in advance their wishes or preferences for what might happen once they do lose capacity. They can complete something called an advanced decision to refuse treatment, which may be legally binding, depending on, provided it fulfills certain criteria. The problem is that an advanced decision to refuse treatment, as it stands at the moment, can only refuse treatments. It can't demand them, and nor should it be able to, because healthcare professionals have a degree of autonomy in deciding whether treatment is appropriate. Termination of life under any change in the law would be classed as a medical intervention. And so as things stand at the moment, even an advanced decision could not request or demand euthanasia once you've lost capacity. Even in an ideal situation, advanced decisions may seem a sensible solution to the problems of decision making once people lose capacity. But in themselves, they're already fraught with problems, not least of which is they make no allowance for a change of mind at the last minute, because you haven't got capacity to do that. And it's difficult to see how one would negotiate that, what happens around the time of actually making that decision. If we were to be able to devise some form of advanced decision where you could decide now for a time in the future when you were to lose capacity to opt for assisted dying, the big question then is, when is it right to intervene? Why today as opposed to next week or next month? Because the assessment and that decision would ultimately fall to someone else and therefore be open to abuse, as we've already discussed. And I guess that leads really on to another area of ethical dilemma, really, insofar as what we mean by personhood and quality of life. When we are well, it's very easy to think of conditions or situations where we just do not think we could ever cope, and actually death might be preferable. And yet, time and again, I come across people in coping and even thriving in situations that are heartbreaking. We tend to assume that mental capacity, that physical function and such like are essential for life to have any meaning, value or quality. And a person with advanced dementia who perhaps can't recognize family members, who has limited function, may from the outside seem to be suffering unbearably. And certainly on the way to that, as capacity is lost and moments of insight, there are moments of insight into that there will be distress. But can we dismiss such a life as a life that is not worth living? Whose suffering are we really trying to address in advanced dementia? Family members very often and very poignantly will say they're not the person that they were. My loved one has gone. And there may be an awful lot of truth to that. But I guess that begs the deeper philosophical question as to what right do I have to make a decision now for the person that I will become in the future when I have advanced dementia. This is a minefield in application. And yet there is another way. We can embrace the ideal that a person's life, no matter how diminished, can have meaning and can be filled with love. And someone once wrote, to love someone is to say that it's good that you exist, it's good that you are in the world. And that when we love someone, loving someone means that actually their lives are safer in our hands than they are in their own. We have a duty to protect and to care for the vulnerable in our midst, and to affirm, support, and get alongside and encourage those who are struggling and suffering to the degree that we're able to. But that, of course, does require commitment. It requires commitment from society, and it requires commitment from each one of us as individuals. And there may be people here who have cared for people with dementia, who have made that sacrifice, who have made that commitment, and I take my hat off to you. The question for us as society, before we think about embarking on changing the law, is, are we prepared to do what it takes to look after the vulnerable in our midst? And are we prepared to bear the cost? Because there's no doubt that assisted dying is a cheaper, easier way of dealing with the situation than investing in good quality care over extended periods of time. And I think my fear is that a society that embarks on the sanctioning of the killing of its most vulnerable is heading down a path that could lead to the dissolution of its conscience and a blunting of compassion. And I don't think that's a kind of society I personally want to live in. But that's a decision for society.
Well, thank you, Stephen. Well, it's not simple, is it? We've heard from Karalyn about the need to treat humans humanely in the way that we would treat animals humanely. We've heard from Geoffrey about the problems and how that treating people humanely has all kinds of implications, not necessarily that it's a matter of just assisting someone with dying. So these are very complicated issues, it's by no means simple. But now it's time in the evening for you to have questions to our panel here, for you to express your views, for you to argue with our panel. Who's going to come in with the first question or statement? Yes, at the front here. Can you just wait? We're just going to get the microphone ready for you. Let me get this one done.
Hi. Yeah, both of your talks were really amazing. I think it's really interesting that you sort of focused on dementia, especially there's so many sort of breakthroughs in there's this sort of dementia, people with dementia that
Where's the other hand?
regular village, and there's a butterfly project and dementia friendly communities, and it's all really exciting. And I think it's almost sort of people making advanced decisions to sort of go for a euthanasia end when they haven't got dementia is, I don't know, they sort of almost don't have that mental capacity to say, I wouldn't like my life like that. And it's also, do you kind of agree with that at the beginning of life, where maybe if somebody's going to be born with a disability, perhaps they shouldn't be born in the first place? Because it seems like they're very similar concepts at different ends of the life spectrum. I don't know. I didn't phrase it very well.
So can we have, but we start with Karalyn and then we go to Geoffrey for that answer.
I think that's a very interesting point about some parallels between deciding who should die and who should be born. I imagine that Jeff will have some interesting observations about that. For example, it comes up in the case of genetic abnormalities, and there are parents who decide that they would prefer not to bring a child into the world who's really going to live in a diminished way, and others who think that that life is precious no matter what the suffering might be. I take the same sort of position on that I do on the possibility of euthanasia and dementia, but I know that it's probably not what Jeff would say and not what many of you would say. So, Jeff.
The issue of the beginning of life is almost more difficult than dealing with people who are terminally ill, really, because you're thinking about not just the life you have, but the potential for life. And I don't. Sometimes I'm not sure what the answer is. I guess it partly depends on the nature of the life that is likely to follow, and the degree to which you need to intervene in order to maintain that. And I think there are certain situations where to strive officiously to keep someone alive, be that at the beginning of life as well as the end, rather than allow a natural death, isn't necessarily the right thing. But these are grey areas, and it would be very hard and we're very harsh to actually be dogmatic with people about the right or wrong of their decision. I think unless you're actually going through that and living with that decision yourself, it's impossible to know the kind of pressures and the suffering that you're going through in trying to make that decision.
Thank you, and thank you for that very interesting question. Now we have one over here, and then we're going to go over there, okay?
I was just thinking, we don't have a law, as happens now, but the courts are already dealing with these cases, and in quite a number of cases they're actually letting the people off, so to speak. I mean, there was a recent case where a relative was supposedly suffocated by their carer, and that was not seen as something that would put them in jail. So in the absence of any law, I beg your pardon, in the absence of any law, then the courts are dealing with this. So I mean, that surely shouldn't be the way that it's done on a one-by-one case. I mean, we are moving towards a situation, because if in fact the judges are dealing with it, then it would seem that the lawmakers, i.e. Parliament, ought to get themselves sorted out as to how they're going to address this issue.
That's a very interesting question. Who would like to go first on that?
I completely agree. This is one of the really unfortunate and complex aspects of this question. As you say, it's not, if we don't take principled decisions, things are happening anyway. And, I have some experience of someone recently being helped to die with Dignitas in Switzerland, who, as it happens, was very disabled by a stroke, but had capacity, mental capacity, and wanted to die. And the police were required to investigate the person in the UK who helped this person to go to Switzerland and die. And then referred the case to the Crown Prosecution Service, and it's their decision, is it in the public interest to prosecute? And I think that's an enormously difficult matter. I mean, in any individual case, you would probably say, the person is dead now, why would it be in the public interest to prosecute and perhaps incarcerate the person who helped them? But, of course, if it, as Jeff was saying earlier, opens the door to a huge number of such decisions, I think, I don't know how to solve this.
So, Jeff, could you perhaps talk about the relationship between the present practice, and perhaps comment on that? That'd be very helpful.
I think the beauty of the way it stands at the moment is that justice can be tempered by mercy. that actually the way it happens may seem messy, but by and large, good decisions are being made. To prosecute and imprison someone who, at the end of their tether, suffocates their loved one as an act of compassion would seem the wrong thing to do. And by dealing with it through the courts, we have the capacity to be lenient in that respect. And that happens across many aspects of decision making in healthcare. A lot of end-of-life decisions that we make at the moment are difficult, grey areas. By and large, it tends to work. And I guess the question is, if we change the law to allow the practice, as I described, with all the potential implications of that, is that making a situation worse in terms of risk to other people? Because generally, although it's messy, justice is done the way things are handled at the moment. People who take loved ones to Dignitas, by and large, are not prosecuted. There are guidelines set out describing the kinds of circumstances where a prosecution is more likely, and one of those very important guideline is that if a doctor, if it's to be seen at all as a medically assisted act, then there's likely to be a prosecution. And I think the beauty of our system is that we've got that leeway. We can temper justice with mercy, and I think it works, albeit messily at the moment.
So we have a gentleman over here, and then we're coming down here.
Hi, I've got 2 points really. Dr. Stephenson, at the end of your talk, you sort of alluded to a society where they sort of had this dispassionate, or began to sort of spiral into a dispassionate view of human life because of this euthanasia practice. So firstly, in terms of like countries like the Netherlands and like Switzerland that have these practices in place to some extent, they sort of consistently score highest on sort of, or, you know, with other Scandinavian countries, sort of standards of living, quality of life, and more recently in sort of cutting edge psychological domains, sort of happiness levels, and sort of, I wonder what you thought of that firstly. And also, as a sort of secondary point to that, those countries also typically have lower levels of religiosity, and I wondered how religiosity played into this debate in terms of the sacredness or holiness of life.
Okay, so would you like to start, Jeff, and then we'll go over to Karen?
So just touching on other places, so the Netherlands or whatever, I mean, I guess that assumes that happiness equates with a compassionate society. I wouldn't necessarily endorse that link. What we do know from the Netherlands, which is the place which has allowed these practices for the longest time, and they've been going 30, almost 40 years now, we have seen a progressive liberalisation of practice, from people with terminal illness who are suffering, to patients with chronic illness, to patients with dementia, to patients with mental illness, to patients who are now simply tired of life, with the ultimate goal, the acknowledged ultimate goal of the equivalent of dignity in dying in Holland being an end-of-life suicide pill for elderly people to take when they want. And that gives you an indication of how public attitudes have changed over the course of a few decades, that there is an increasing acceptance, and what starts off as a small, limited intervention inevitably expands. But not only that, becomes subject to abuse. Over the years, there are thousands of people in the Netherlands who have been killed who did not ask for it, many of whom did not want it. And now things have changed to a degree in the Netherlands that actually the assumption is you will want euthanasia, and you need to be very clear when you go into hospital that isn't what you want. And so I guess just to progress, it's kind of a picture it's useful for us to look at the Netherlands. So actually this is what can happen when you allow this kind of thing. What was the second one was on
religiosity.
religiosity. Religiosity is. It isn't quite as clear-cut as one might expect. One would expect that very religious people might be very opposed to euthanasia. Certainly within the Christian faith, that's not the case. That actually there's a broad opinion within Christianity. Many people would see helping someone die a peaceful, painless death, if that is what they want, is the logical expression of our love for them, and will argue on some points of scripture to validate that, whereas others would say, thou shalt not kill under any circumstances. This is simply not biblical. So, surprisingly, there isn't a huge correlation with religiosity in terms of opinions on this, certainly in the UK. Whether that's the same in Muslim countries or I don't know, but certainly in the UK.
I meant just all society in general, because I know a lot of standing income people are typically lower.
Yes, maybe, yeah.
Okay, thank you. We have a question from the gentleman at the front.
I just wanted to say a couple of things. First of all, I mean, we're talking about dementia as a discussion point, and I think we're kind of also talking about the situation around people actually going off to Switzerland and not having the same opportunity to do that in their own country. And I think the two things are completely separate. Where people, actually make a choice that they don't wish to live, and they've gone through a whole range of counselling and talked about it and worked it out with their loved ones and decided, I don't want to suffer this pain and this is what I want to do. I think that's a very different discussion. I think we're kind of like polluting this discussion with both of those points, because actually it's very different than when a person like myself would choose to do that, as opposed to if I were to actually lack mental capacity to make that decision for myself, because then the people looking after me have to have a duty of care to me. They have a need to look after me, and certainly medical professionals would have, they're concerned with the welfare and health of people, and so that's a real tough dilemma for them particularly. But we do have, so I'd like to see the law change in terms of people who have capacity to make the decisions for themselves and to make provision for that and not have to travel great distances. And certainly, although I think it's already acknowledged that when their loved ones come back, they're not generally treated too harshly by the court. But where someone lacks mental capacity, we do have with the Mental Capacity Act the opportunity to make a lasting power of attorney, to nominate an attorney, and that attorney, and you can actually you have to specify it, but you can say that you wish to not have life-sustaining treatment, so you can make that choice for yourself when you have capacity. And I appreciate all the different points that were said about actually, what happens if you want to change your mind. The other point I just want to say about dementia is that not everybody who has dementia has a very poor quality of life. There is at certain times, of course, distress, but there is also actually times where there's great opportunities to fulfill your life. And I know on a personal level that actually life is a little less complicated for my granddad, but actually, generally, he's far more happy, I think, than at times than without all the worries that he may have had. In terms of the religious bit, I think that suicide you can't really make it illegal because there's no one to prosecute. If a person actually commits suicide, you can't really take them to court. I guess if they fail to commit suicide, then the last thing they need is to be prosecuted for that. They will obviously need lots of support to prevent that in the future. But I think we need to clearly distinguish between people who have dementia and need our care from people who have mental capacity to say, I'm choosing to do this.
Good. So shall we start with Karalyn on that, the dementia versus people who have capacity?
Yes, of course that is a very important distinction. And as I tried to indicate in my little talk, I think the issue of capacity is by far, in a debate in which there are many minefields, that's the biggest one in my view. There are two things I'd like to say. One is, as Jeff pointed out, people change over the course of a dementing illness, and also, and we haven't touched on this yet, not all forms of dementia are the same by any means. The most common ones that we're confronted with by virtue of their extreme frequency, Alzheimer's disease, some of the dementias that are associated with Parkinson's disease and so on. But there are many other forms of dementia as well, and they're not all the same, and that just complicates things further. And as you say, not everyone's life with dementia is unbearable at all. But I'd like to make two little points. One is, who is the person who is most likely to know about whether someone without capacity would choose to live or die? I think the two most likely, the closest, are, first of all, that person at an earlier stage of life when he or she still has capacity. We don't ask patients, how would you feel about continuing to live if you were in this kind of situation? It's so complicated. But we could think about the possibility of trying to find out how people would view their own lives if they were failing to recognize people, unable to look after themselves, unable to take any decisions, etc. Secondly, I think the next person who's most appropriate or relevant is the closest carer, spouse, partner, whatever, of that person with dementia. And I know from dealing with a lot of carers that they very often feel this person would be better off not living. So acknowledging all the complications, I still think that there are situations in which, despite the lack of capacity, there would be relevant information about the choice to live or not to live.
I mean, I don't think I disagree with what you said, really. That clearly, if the law were to change, then the capacity is fundamental to that, and the whole reason for the law changing will be for that group of people who say, well, actually, the time has come, I want to take that option. So I wouldn't disagree with that at all. I think the only point that I was trying to make was at what risk, at what cost to others, and some of that is just unknown. But I guess that the reason for this talk is that applying that to the situation of dementia is as we've seen, fraught with difficulty because of the whole issue of capacity. And my worry with a law that allows those who have capacity, who are able to decide for themselves to end their suffering however they perceive that, that excludes those who we deem to be suffering equally, but who can't have that option. And that's why I personally think that expansion is simply inevitable. Logic demands it. And that's, I guess, my sticking point, really.
Good. Yes, we've got a point over here, and then over there.
Hi. I've worked dementia most of my working life, and recently lost my mother-in-law last July to Alzheimer's. I'm stage 3 lupus. I've got an advanced directive, and I've made wishes for an exit, basically. I've been listening to what people are saying, and one of the things that's come across is that because a person with dementia lacks capacity, they haven't got a right to be able to choose whether they stay or whether they exit, which I think is totally wrong. I've made my advanced directive. My mother-in-law made hers 7 years ago when she was diagnosed with Alzheimer's. Although she couldn't state that she wanted to exit, she did say that she didn't want to suffer, she didn't want treatment, she didn't want resuscitation. And I think there is a way forward if euthanasia should become legal, is that within an advanced directive or decision, we could stay at what stage we would like to exit. So therefore, with any kind of dementia, which you say there's over 100 different types of dementia, We could say, for instance, that when it came to the time when we'd lost both mental and physical capacity and being able to, not to do anything, that would be the time that we could exit. There is a way forward, but it's just a matter that we have to agree this legally. Euthanasia has to become legal for starters, which I don't think it ever will. Not in England anyway. And I totally disagree with the fact that, for me personally, I have to go abroad and die alone without my family because I don't want to suffer, when in fact it would be nice to be able to stay at home and have my family around me and not have them held responsible for my exit. And I feel that people with dementia, and having worked it all my life, I have a master's in dementia, that they haven't got that choice because unfortunately they lack capacity.
Okay, so could we have perhaps Karalyn first? The issue of the precise, a much more precise advance directive, how would you feel with that?
Yes. Well, as I mentioned, we don't ask people that we see in clinic, you know, under what circumstances would you prefer your life to be terminated? The closest, in a way, that we get to that is because we do research on various forms of dementia, in my case particularly rather unusual forms of dementia, and we study people as they progress through the course of the disease, and we do brain imaging, we do lots of behavioral cognitive tests, so we have a great deal of information about the course of the disease. And one of the most valuable things from the point of view of our research is to know exactly what the underlying brain pathology is. As many of you may know, you can make a pretty good guess in many instances, but you can almost never be absolutely confident what the pathology is while the person is still alive. And we sometimes have surprises. Because it's so valuable to have that information, we do try, after the initial shock of the diagnosis is over, but while the person still has reasonable capacity, to discuss with them whether they'd be willing to donate brain tissue when they die. Those are difficult decisions and questions and discussions too. And my one thought has been, could we perhaps have a somewhat similar conversation about the advance directive?
So Jeff, could you comment on the issue of the more precise advance directive which this lady asked?
I think that the trouble with advanced directives generally is that they are very difficult to draft to be exactly what you intend when the time comes, and trying to envisage a situation of deteriorating capacity and function, how do you, I mean, if you could, great, but how do you define the specific point at which your capacity goes beyond that line, your function goes beyond that line? That's going to be open to interpretation by those who are caring for you. So it is going to be messy and open possibly to abuse, which, as I said. I mean, just picking up on what you said about why should I have to go to abroad to get this. I can fully sympathise with that view, and clearly you have an awful lot of experience with dementia. All I would say for that is that yes, it is available abroad, but that doesn't necessarily invalidate the arguments as to why we shouldn't be doing it here. And I know that's a very difficult tension to maintain, because for people who want to go to Dignitas, actually they probably need to end their lives earlier than they would if it were available here, and that is a tragedy. But it is still their choice, and needing to step back from the individual and looking at other vulnerable people, I guess that's what guides decision making. The other point, if I can, just on, in terms of identifying a point at which you would say, well, I want euthanasia at this point. Of course, when you lose capacity from advanced dementia or whatever, we have the option of saying, I don't want any treatments that will prolong my life. And the elderly, the frail elderly, are often very susceptible to infections. You know, it's entirely appropriate and legal at the moment to say, well, I do not want any antibiotics, full stop. I do not want to go into hospital. I do not want any intravenous fluids. There are ways of allowing yourself to have a natural death and avoiding the medicalisation and prolonging of life, which kind of get round the need to actually have someone euthanize you. So there are ways already.
Okay. So we've got one question here, and then one. Okay, one here, and then we've got. We carry on. Okay, that's right. Yeah.
The question about euthanasia is who's taking the responsibility of deciding. And countless of times my gran asked her daughter to push her down the stairs. Then when she was bedridden, she asked for a pillow. Then she lost her head and couldn't recognize anyone. Anyway, she stopped asking for it, which somehow is maybe because she didn't have her mind straight. Personally, I wouldn't like to be a burden, and I wouldn't like to lay the burden of taking the decision on anyone close to me or anyone caring for me, like professional. So I would see, in a very self-centered view, I would like to decide myself on my way out, like I decided to give my organs if I ever die. I wouldn't like anyone to make that decision because it's not an easy decision, and actually it would be then the survivors to live with that decision, and I think that would be a nice way of going out if it's just like not asking the survivors to take that decision for me.
Okay. So could we both comment briefly on that, because we've got several more questions to come.
Okay, I'll be brief. I completely agree with you. The only snag there I see is the one that Jeff raised earlier, which is the possibility of a change of mind after the mind is no longer working well.
Okay. So we have lady. Okay. Yep. The red, yes, and then at the back.
I would just like to comment on something that Dr. Stephenson said. You said that the situation now in the Netherlands nowadays is that when you enter a hospital, it's the expectation that you will want euthanasia. Now, I come from Belgium. I've worked there several years as a social worker as well, worked closely with hospital. In Belgium, euthanasia is legalized. And I wouldn't like the thought that people think that in any other country where euthanasia is legalized, that people enter hospitals and that medical professionals have the expectation that the question for euthanasia will come. So I disagree with that. I have the experience that people are very careful with euthanasia, and that it's much more a situation of having the conversation, having the possibility, but treating it very, very carefully. So I just wanted to comment on that I don't agree with that comment.
Well, thank you. That's very useful. Should we?
That's fine. I apologise. I don't want to offend anyone. I'm simply quoting from evidence that was given to the House of Lords Select Committee, and I've no experience of the Dutch system myself. I've never been there. In fact, I've hardly spoken to people who practice there. I'm simply quoting evidence, and if the evidence is wrong, then I apologise for that.
I'll just say it is coming up to past, but the speakers have kindly said we could go on for another few minutes if there's more questions, and there clearly is an appetite, so we will carry on.
We'll take another one, two, and then there's one over here. Perhaps we need to hold.
Hello. I'm here with a couple of hats on because I'm a non-practicing private client solicitor. I also work as an NHS continuing healthcare specialist and advocate for the elderly. And I'm also an advocate for the Alzheimer's Society, and I'm currently promoting the Dementia Friends initiative, and I'm a Dementia Friend champion. You've talked a lot about advanced directives and having prepared a number of those in the past when I was a practicing solicitor. I know how very complicated they are, and in some situations they worked and in others they didn't. With regards to lasting powers of attorney, I've seen two sides of the coin with those, in that lasting powers of attorney for health and welfare can be a little bit misused by those who become attorneys, because in some cases people are looking at preserving their inheritance rather than preserving the life of their parents, and I hate to be harsh, but that's the reality. You also talked about choice to die, and what I'm finding now, I visit a lot of care homes where I carry out continuing healthcare assessments, and what I'm finding is that under the Mental Capacity Act, Section 5, the best interests decisions are being misused, and that a lot of my clients, to my horror, have actually got TEPs in place, treatment escalation plans, which were formerly known as DNRs, do not resuscitate. And sometimes the attorneys don't even know that, that they've got them in place. And these are being used, they're supposed to be used for someone who is approaching the end of their life, and they're not, and they're being signed off by GPs and upon discharge from hospital. And I would argue that in some ways euthanasia has been introduced in the UK through the back door, and we don't realise that it's there.
So that's a comment that euthanasia is actually here and alive and kicking, as it were, away.
And the issue of do not attempt resuscitate is a very important one at the moment with the introduction of these new treatment escalation plans, as you say. And I think it's fair to acknowledge there's a lot of work to be done in educating people around having the right conversations. I wouldn't say that not resuscitating is necessarily euthanasia by the back door. I think there are situations, or very commonly, as people progress in their illness, where attempting resuscitation, and one needs to remember that attempting a resuscitation is a medical intervention, and it's a very brutal medical intervention, resulting in broken ribs, and if you pull through, probably time in intensive care, and only a small proportion, a very small proportion of people towards the end of their life actually make it out of hospital if they survive it. So we actually ought to be thinking more in terms of justifying offering it rather than necessarily justifying why we're withholding it. Now, but clearly the conversations around that are very important, and it shouldn't simply be done behind people's backs.
Okay, good.
That's
Okay. Okay. So we've got a gentleman at the back, I think. Oh yes, there you are. Hands up there. Yes. I haven't got my glasses. I've lost them, you see. I was saying to Karalyn, I have left them on the train. So I'm sorry.
I guess there are lots of issues regarding the policing of euthanasia, but I was more, my question is more for the audience rather than the speakers, which I just was interested in what the feeling is about euthanasia in the audience, and whether people are more pro than anti, because there seem to be, there's still a sort of medicalisation of the arguments as to whether people should be able to have euthanasia or not. So that was really what I was interested if people would be willing to participate with a show of hands of whether they're...
I was actually going to do this right at the end.
Okay, sorry, I'm still...
We have one more question, and then I will, so this, I think it is a gentleman, I'm sorry, I'm so sorry. But your heart, yes, hand was here.
Yeah, so I have just been a lot of talk about euthanasia in the UK versus in the Netherlands. And so my background is I'm a Frenchman, and I have just lived for about 4 years in the Netherlands. And I think there's a vision that the Netherlands is an extremely liberal society. And I was very surprised to find out that this is not so much the case, and that compared to France at least, and I think this is fairly similar in the UK, so I'm not able really to say that for sure, that in the Netherlands there's actually a very normative society. There's a lot of pressure for society as to how to behave, how to act, so they have legalized a lot of behavior, but in practice society is such that a lot of things remain impossible or discouraged to to such extent that they don't happen in practice. And there's also a very important role of family compared to my home country. And I wonder if, so when we discuss legalizing euthanasia, I think from country to country, the role of the law might be so different that it might be very different things in practice. So the effect of changing the law in the Netherlands might not be the same at all as changing the law in France or the UK, because society works differently.
Thank you. Okay, so a brief comment on the issue of changing the law. The laws change from country to country and has implications.
I mean, I think you may well be right. I think I should stress that I have no intention of vilifying the Netherlands tonight. It's just the Netherlands is very, very useful because we can, and the eyes of the world are on the Netherlands because they've had it for 30, 40 years and we've been able to see how something evolves. Whether the same laws in a different culture, different structure of the legal system would have the same effect, I don't know. You're very right. I mean, all I do know is I think the intention in the Netherlands one could not argue with if you're trying to frame a law. I think the problem comes around the safeguards, and it's what I alluded to in my talk, that it's very difficult to draw up robust safeguards. And the evidence suggests that actually the safeguards in the Netherlands, for whatever the intent, are probably not working. And again, I'm quoting evidence because I haven't been there, but the United Nations Human Rights Committee consistently, on many occasions, has expressed concerns about the extent of euthanasia in the Netherlands, and in particular, the inadequacy of safeguards. And I think that's the learning point in this. It's not to vilify the Dutch as being, somehow a different sort of mindset, but it's actually just see here's a microcosm. This is what it looks like in a particular society. These are the problems. These are the things that we've seen develop. How are they trying to prevent it? And actually, could we actually do any better? Because it's very difficult to see how we could.
Okay. Good. Well, you've heard the arguments. You've heard the problems with both ways. Now is the time for you to vote. I want you to imagine, and it's not a nice thing to imagine that you've just been diagnosed with dementia, and you have to make a decision as to what you're going to do. Are you going to tell your nearest and dearest that you would like an advance directive, that's your preference, or are you not? Let's see a show of hands for those who would want to have an advance directive which would euthanize them when they become totally incapable. Okay, and I won't count, I'll just do it by visual gaze. And those who definitely would not do it. Okay, well, I would say it's about a third would, sorry, 2/3 would to a third wouldn't. But what it also illustrates is that there's a difference in opinion. And I think that's one of the things we've learnt this evening, that there are strongly held views which are in different ways. Just got a hands. Is that another question or?
Well, yes, a brief one.
Are we?
To Stephen, really. Well, it hasn't been raised so far at all.
Okay.
Very briefly.
Very briefly.
Very briefly.
Very briefly.
All I was going to say is reductions in the science is prevailing.
Yeah.
Science is basically still the establishment of science is basically reductionist. So do you in your clinical work ever ask yourself the question or have the problem of what is the human being? Is he conscious? What is consciousness? And the brain-mind equation, is it independent of its physical housing or is it not? What is a person? How do you deal with that?
That would have to be a very quick answer. Not a very complex question. Have you ever thought about that, Stephen? Yes or no? Jeffrey, sorry, Jeffrey.
To be honest, I don't think about that an awful lot. I'm so engrossed in actually dealing with what's in front of me. I mean, I don't want to dismiss the question, but to be honest, I couldn't do it justice in 30 seconds at the end of a debate like this, because it would leave you, you'd go away with all sorts of questions you want to come back at me with. So I'd really prefer not to answer it, if that's all right.
Okay, so thank you very much. So, look, I think it's been a fascinating evening. It just remains for me to thank our two panellists and to thank you, the audience, for your wonderful contribution. Thank you and good night.